Good morning, and thank you very much, Dr. Khamar, for this opportunity to be here. So whenever we see patients with glaucoma, the first step is that we need to confirm the diagnosis. And for that, we require the intraocular pressure, the optic nerve, the visual fields, and the gonioscopy findings. Because the gonioscopy findings will help us to identify the next step, that is to confirm the type of glaucoma the patient has. Because treatment is going to be based on the type of glaucoma. Gonioscopy here becomes very important. So it's easy to identify an angle. Can I have a pointer, please? So it's easy to identify an angle which is open or an angle. More importantly, I think we need to identify an angle which has open but has a tendency to close, because then the diagnosis will be angle closure. We need to be able to identify closed angles, and we are also concerned about angles which are neither open nor closed but narrow, because these angles will never close over a period of time. Some will, we need to be able to judge that. So the key to right glaucoma management actually requires that we make the right diagnosis. And for the right diagnosis, we need to do the gonioscopy. So the first thing is to choose the right lens. A Goldman single mirror or two mirror, or a Zeiss 4 mirror or a Sussman 4 mirror are good options. The retina 4 mirror is not to be used for gonioscopy evaluation. Now, this is a case profile of one of our patients, a 46-year-old who had raised pressures of 33, 46. She came to us, she was on brimonidine timolol combination. This is what she had a best corrected visual acuity of 6.6, cornea adjusted pressures are 20, front of the eye looked like this, and when we did the gonioscopy with the 4 mirror, we found that the mid peripheral iris was bowing anteriorly, and there were actually, you can see some synecdoche here. But when we did the gonioscopy with the 2 mirror, the Goldman 2 mirror, we found that there was an incomplete separation of the iris, and you can actually see that what we were looking at was a mesodermal dysgenesis of the angle. So the diagnosis here was not angle closure as was evident from the 4 mirror, but was actually mesodermal dysgenesis. This patient also had a maxillary hypoplasia, but no dental changes. The second thing we got to look at is the technique by which we are doing gonioscopy. So patient should be looking in primary position, light should be dim, and the size of the contact lens should be such that there's no compression, and similarly we should not be pressing by asking the patient to look down or in a different direction. Initial evaluation is always in a primary position. Then if you see an angle which is open, you reduce the width of the beam to see if you can get this angle to close. So you can see that this angle is open here. You can see the ciliary body band, but as the beam width is being reduced, it has actually gone into a closure. So this patient with open angles actually had angle closure. The other thing is when you see an angle which is closed, you ask yourself, can I get this angle to open up? And this was more important when laser iridotomies were not available and surgical iridectomies used to be done. So they needed to differentiate. If they saw synecdoche, they said, we'll do a trabeculectomy. If it was appositional closure, they opted for a surgical iridectomy. So this is where indentation is also done. The other thing in gonioscopy is to identify structure. So easy to identify the ciliary body band as a gray structure with a variable amount of pigment, which you see here. Then you could identify just anterior to that the scleral spur, and then just anterior to that will be the trabecular meshwork. One of the points of concern would be when you see multiple layers of pigmentation in the angle, then the posterior-most layer represents the trabecular meshwork. So you see a pigmented layer here, 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 and here. So this is actually the trabecular meshwork. Again, just anterior to the trabecular meshwork is the shawl-based line represented by the yellow marker here. The important thing is you can create the corneal wedge, but I have never been able to take a good picture of the wedge. So this is perhaps the only picture I have. The apex of the wedge represents where the corneal shawl-based line is. Another situation where we can see here is that there is a widening of the trabecular meshwork. More importantly, look at this nature of the pigmentation that you're seeing here. Pigmentation of the trabecular meshwork is fine and diffuse, while pigmentation on the shawl-based line is more coarser, like a pepper granules. And this is also called as a Sampolosi's line in pigmentary glaucomas. The other thing we look at is Schlemm's line, which is actually a widening of the trabecular meshwork, and you can get a reflux of blood into Schlemm's canal. Typically see them in patients who have a raised episcleral venous pressure. So again, just to show you sample OC's line in a patient with pigmentary glaucoma, very coarse nature of the iris pigment granules on the Scholl-based line. Then you see patchy pigment on Scholl-based line here, which is suggestive of past closure, even though you can actually see the ciliary body band in bits and pieces. Same thing again here. Angle is nice, wide and open, but this patchy pigment is a telltale sign that this angle has a tendency to close. We can even pick up blood vessels in the angle, and pathological blood vessels are those which cross the scleral spur. Contour is important. You see a concavity of the iris insertion in myopes, aphakics, and developmental glaucomas, and peripheral convexity in patients with angle closure. So this is important. It's important to grade. Now the problem in grading is an open angle and a closed angle is easy to identify. Your technique should be right, but grading is very important. Now there are multiple systems of grading. In one system, 0 represents closure, and in another system, 0 represents open angle. So whatever system you follow must be documented so that the person who sees the patient after you knows what is happening. A simpler way to do it is to base it on the structures that you are seeing. For example, posterior-most structure seen here is ciliary body band. You mark on the goniogram ciliary body band, then see if you can get this angle to close. As I've been showing you repeatedly, it has closed. So on the goniogram, you represented ciliary body band with a tendency to close. So your diagnosis here will be angle closure. You can mark out other telltale signs like a goniosynechiae as you're seeing here as a representation on the goniogram. And if you see an angle which is closed, you got to see if you can get it to open by asking the patient to look in the direction of the mirror and document accordingly. Now all narrow angles do not close, so we need to differentiate between those which can and those which will not. So the important thing is asymptomatic closure is common, and a gonioscopy must be done for all our patients or glaucoma suspects. To assess occludability in patients, we must make sure that our technique is right. Open angles, do they have a tendency to close? Look for goniosynechiae, patchy pigmentation on Scholl-based line, and the classical on-off sign where you see this angle narrowing further as light was being reduced, and there's a peripheral convexity of the iris which is happening here. So gonioscopy is a very simple technique. It's inexpensive, and that's where the problem lies. Because it's inexpensive, we as ophthalmologists don't value it, and we are not able to transfer this value of this procedure to our patients. It's subjective, and it involves contact with the eye, so there's a coupling media which is used. More importantly, illumination is required as compared to the UBM, and therefore there is a possibility of the angle status changing, routinely not being done as a procedure, and therefore we have difficulty in identifying. So it's not being done and it's not being taught, and therefore the problem happens. And again, being subjective, what may be open or occludable for me may not be for another person. So that's again a problem that we have. Thank you very much.
Thank you, Devin. It was a very nice presentation.
Thank you, ma'am.
But we have to say that intersegment imaging is also good technique. So
That wasn't the topic given to me, ma'am.
yeah.